Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 76 of the Movement Debrief. And tonight, folks, we got a slobber knocker on our hands. We're going to talk about rotator cuff tears. Not just, oh, you got a rotator cuff sprain, something or other. Do you get surgery? Stay tuned. I'm going to tell you what you're going to do about that. We're going to talk about posterior pelvic tilting. Why is this important? Is there any time you wouldn't want a posterior pelvic tilt? Have I got your attention? Last but not least, we're going to talk about finding good clinicians. What qualities should you look for if you have to refer out to someone, whether it's a therapist, a chiro, an MD? What you going to do? Who you going to find? These are questions that I'm going to answer tonight, and they were asked from the people, answered for the people, by this people, fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from Kelly. Hey Zach, here are some possible things I would love for you to discuss. Let's talk about normal, conservative treatment of a rotator cuff tear versus more breathing-based interventions. And for those who have been sliced, rotator cuff repair, am I following a normal rotator cuff tendon healing period post-surgical protocol? How would we progress athletes for maximum benefit? Kelly, my homegirl, excellent question. Let's dive into this. I always struggle with conservative or normal or general exercise and these types of things because I've worked with a lot of different PTs and clinicians, and I've never seen the general program. Everyone's approach runs the gamut. But when I think of conservative or traditional rotator cuff repair, much of this stuff surrounds strengthening the periscapular muscles as well as the muscles of the rotator cuff, and likely restoring some joint range of motion as well, which to a degree is similar to what I do. All I do is I take it one step further, and that's going a bit more proximally and appreciating the proximal influences to go that same route or get the same outcome that they're looking for. Because if you're a good clinician, you're probably looking at restoring mobility and building up conditioning of the tissue so you can return, or the people you're working with can return back to whatever task they need to do. That would be the big difference. From my perspective, for someone who's got any type of shoulder issue, regardless if it's a rotator cuff tear or impingement or just general pain, almost all of the muscles that attach to the shoulder either attach somewhere on the scapula, they attach somewhere on the rib cage or the sternum, or they attach somewhere in the thorax. One of the most influential ways that we can impact the thorax is through breathing. Because every time you breathe in and breathe out, your rib cage has to move. That influences the foundation to which the shoulder sits on. Because your scapula sits on your rib cage, and your scapula influences your shoulder positioning and orientation and actions. If you're not taking into account the base, you're probably missing a few things along the way. That would be the biggest difference, I would say, between those two approaches. And yeah, some clinicians do focus on T-spine mobility, but if you're not taking into account the ribcage influence, I think you're probably missing something. When I'm working with someone with a rotator cuff issue, if we can even diagnose that, who knows, the approach looks very similar to anything else that I would treat. I'm making sure that I can maximize the ability to establish bucket handle, pump handle, and posterior thorax expansion in the rib cage. If we can improve that mobility in all those areas, that can potentially alter the contractile orientations or length-tension relationship of the muscles in the periscapular and shoulder region, which hopefully would increase the amount of movement options available for someone who has a shoulder issue. That could potentially help with pain. If you want to learn more, I'll link a bunch of shoulder debriefs in the show notes. Thorax shit, we'll say. But yeah, it'll be there if you want to dive deeper into that. But you basically have to be able to get the rib cage to expand in multiple directions, and that oftentimes restores most range of motion more often than not. Some interesting things that I've been noticing just this week in terms of cleaning up little bits of range of motion, because I think shoulder external and internal rotation and flexion, pretty easy peasy lemon squeezy to take care of if you follow some of this stuff. But what can be challenging is making sure you get full horizontal AB and AD duction. Things I've been utilizing in particular for that is, for horizontal AB duction, is making sure someone can touch their toes and achieve a full squat. That's been huge for me, and I got to give kudos to Daddy-O Pops Bill Hartman for inspiring me chasing that a bit more. Because if you can get into a full squat and you can touch your toes, then you for sure are likely to be able to maximize your posterior thorax expansion. What that does is that allows the scaps the ability to be able to AB duct, which can allow for horizontal AB duction to restore. Because many times if the scaps are in a more AD ducted orientation, that can, by nature of us righting the arms for purposeful movement, so if this is we got a scap here, we got a humerus here, no joke. If let's say my nose is the midline, if I AD duct towards my nose and my arm, my humerus follows suit, well, in order for me to do something in front of me, I have to horizontally AD duct it. This gives the subscap concentric leverage. So if you can do something that expands the scap out into abduction, that may normalize that orientation. Full depth squatting, huge for that. It's been something that has reliably allowed for improvement of the horizontal abduction limitation. Another thing that I've been looking into a lot more is cleaning up horizontal adduction, which the reverse rule would apply. If the scap is way abducted and the humerus is to follow suit, well, in order to right it to midline, I may get concentric orientation of stuff posteriorly. What I've been using for this, and it's worked really, really well, is something that you need to abduct the scapula for, arm bars. Not just the straight arm bars, but doing a side-lying arm bar. I've had a few people this week where we've tried full depth squatting, and they can squat ass to grass. And everything's clean except horizontal adduction. And I was trying a bazillion different things. I was trying some local rotator cuff work, much like you would do in this conservative approach that we outlined before. Wasn't getting anything. I decided, let's try an arm bar, making sure you reach as far as you can to the ceiling. Butter. Cleaned up horizontal adduction, and in this woman in particular, she couldn't abduct the shoulder past 90. Was money. I'll link some of my favorite variations of squatting and the arm bar in the show notes. But those are the things you want to consider. Making sure you've restored all of the movement options available in shoulder one, and then you treat them like anyone else. Get them freaky strong, make sure you're doing pressing, you're doing pulling, you're doing reaching activities, anything to load the tissues so you have an improvement in tissue conditioning. Because if you have options and you got well-conditioned tissues, you're probably going to have a healthy joint in this case, or a healthy rotator cuff, without having to do any of the band shit. But let's say someone ends up going under the knife, and that is most certainly warranted in a lot of cases. For the second piece, do I follow the protocols? Kelly, I absolutely follow the protocols from a normal healing time standpoint. Typically, most rotator cuff surgeries have a 6-week period where the patient is not allowed to move the arm. The reason why is because that allows an ample amount of healing time for the tissues that were repaired. If you perform an active contraction of the muscle that was repaired, you run the risk of tearing again. No bueno. And there's some evidence out there, I can't remember the exact study, it's been a while since I've read it, so it may be updated, but there is some evidence out there to suggest that sometimes doing early passive range of motion can increase the risk of a re-tear. And many times that's because as you're doing passive range of motion for someone, they often help because, well, they have muscle guarding, they just had a surgery. I get it. So you have to respect the healing times. Like there's nothing that, any of the breathing stuff that I can do that can make this stuff heal faster. When I think of any type of protocol, whether it's rotator cuff, knee, anything, the big thing that I look for is what can't I do right now? For rotator cuff, that's usually a passive range of motion for 6 weeks. 6 to 8 is active assistive. 8 and beyond is active. And 12 to, I think like 10 to 12 weeks would be you can start loading. That's a good rule to follow. And it's, one, covers your butt, but two, it also ensures that the tissues heal. You want to make sure you follow that. But any exercises that are suggested, I usually take the paper and I throw it out. Because the process is still the same as it was when I was discussing the conservative treatment of rotator cuff repair. You still have to restore joint range of motion. You eventually have to build up tissue conditioning. And I really approach the process the same way. The only difference is I'm choosing activities and I'm performing manual interventions to the rib cage that don't allow for active contraction of the shoulder. And you would be amazed that by doing that, by making sure that you have all of the rib cage mobility restored, those actions that I discussed before, pump handle, bucket handle, and posterior expansion, that cleans up a ton of the range of motion limitations that you often see post-operatively. And it does so without putting the patient at risk of a re-tear or being painful for that matter. Aside from the pain that oftentimes occurs with some of the ribcage work. That's usually how I go about things. I also like, while we're in that passive range of motion phase, I actually wrote a post on this a long time ago about sexifying post-op. A lot of the things I said in that post, which I'll link in the show notes tomorrow, reign true. You still can do some conditioning during this time period. I'll encourage a lot of my people to go for walks or do some type of cardiovascular work. And a lot of times in session, we're training the arm that wasn't surgically repaired as well as legs. And another thing that I will often do is I will have them visualize doing the same action with the arm that they had surgery on. There's a post I did a long time ago on graded motor imagery. Some of the research supporting that is legit from a strengthening standpoint. And I find that once we actually get into the conditioning or the reconditioning phase of things, they pick up the movements way quicker and you have to do way less coaching because you've coached it on the other side and they visualize themselves doing it on the side that hurts. Those are some of the big keys I think you need to consider when you are working with someone post-operatively. And in terms of progressing athletes for maximum benefit, I really think you stay along the exact same progression as I did with anyone else, and then you're working towards drill activities that would bridge the gap from whatever task they have to do. So if I'm someone who's an overhead athlete who needs to throw, they probably need to be doing throwing-like things. Maybe that's medicine ball throws, or maybe even working on long toss if it's baseball, or just anything like that. But you just want to think of ways to bridge that gap. And so if it's a throwing athlete or an overhead athlete, they probably need to do fast velocity things as well as things with weight to prepare the tissues to be able to tolerate that activity. And then it's a matter of getting them to activity and progressing them in a reasonable manner from not just, say, doing the physical movements, but also from a loading and a load management perspective. Those would be the big rehab keys that I'm seeing for athletes. So to summarize, Kelly, your question, normal rehab versus what I do, similar goals. I just make sure I appreciate the ventral cavity and work on the base. The base involves being able to expand the rib cage in all directions, restoring range of motion by utilizing that process as well as others. Once you have full range of motion, then you are looking at reconditioning the tissues so they can get back to whatever they want to do. From a post-operative standpoint, you most certainly want to follow the protocols insofar as respecting tissue healing times. But you can do the same stuff. Just make sure you're not doing anything active. A lot of rib cage work works wonders. If it's athletes, you just got to progress until you are doing things that are close to the terminal activity. Once you get to the terminal activity, make sure they do it well, and then progress the amount that they do. And if you do those things, Kelly, you ought to be in business. Kelly, awesome question. This next question is brought to you by Topo Chico. And it comes from Dave. Wait, no, it doesn't. Wait. Yes. It comes from Tim and Chase. That's going to be next week. You're going to like that one. This next question comes from Tim and Chase. It was a combo question, 2 for the price of 1. I got you. So, what is the purpose of the back pocket tuck that is often called for in most of the activities I prescribe? And then Tim's portion is, in what context would a hip tuck not be appropriate? Or when is maybe emphasizing an anterior pelvic tilt or orientation and lumbar lordosis the appropriate intervention? Tim and Chase, unbelievable questions. Let's dive into that. So, posterior tilt or tucking, the big key with that is you want to tip the hips backwards. Or you also want to create a little sacral counternutation. Both are very similar processes that we are working on from a local standpoint. Why is that important? Because if you watch me posteriorly tilt the pelvis, like that, if I look at the femur, what's occurring is hip extension. Most people don't have hip extension. Most people are in some type of anterior orientation. How am I looking at that? Check hip extension on most people. You can use an Ober's test. I don't care what you use. I use Ober's test. I also look at any single leg activity. I look at split squats. I look at all of these things to let me know, hey, this person can't do this. Emphasizing the posterior tilt also oftentimes will allow for a lining up of the pelvic floor underneath the thoracic diaphragm. We need to stack these two things so we can create a piston effect. That piston effect is going to allow for movement options to be available in the pelvis. One, because if I can do this, inhale, tilt it back, exhale, push it forward, I likely have all degrees of freedom available in the hip joint. Because as the pelvis tips back and forth, the hips have to do certain things. And if they can't do those things, you probably have to figure out a way to get them to do those things. So that would be one piece why you would do the back pocket tuck in most activities. If the name of the game is hip extension, you got to go tuck yourself. Now, is there ever a time in which you wouldn't want to emphasize the tuck? I think yes. There's one patient who I can think of in particular, and that would be if the tuck or getting any type of reduction of the lumbar curve is painful. And I had a patient once who was this case. She had really nasty back pain. And with that increase in back pain, anytime we got her to get any type of rounding whatsoever, it was a problem. I'm not going to put a square peg in a round hole. So what I did with her, and this worked really well, is I actually put a lumbar roll or like a half foam roller underneath her low back. And I had her start in a lordosis. And then I just had her breathe in that position. And we were able to get some changes in testing and some changes in symptoms. Then from that position, I slowly had her start tucking. So instead of putting her at the end range of the tuck, I took her well out of that. I put her in a position that she was comfortable in. And once we had that established, boom, we had some success. We got some really nice changes in testing. We got some good symptom relief. Wasn't perfect, but it was a great starting point. So if you see someone who that tuck is no bueno, you might consider starting them in a lordotic position or maybe emphasizing a degree of anterior pelvic tilt. But I've only done that one time in my entire career. But it's a possibility of something that could happen, just to consider. Another time when you might not consider doing posterior tilting would be some high-level activity. It's not really something I'm necessarily cueing at top-level sprinting or with jumping or things of that nature. Because if I'm doing some type of activity that's a lot more intense, you typically don't have the mental capacity to think about those internal cues and be able to perform at a high level. If you're just teaching the concepts and your goal is not maximal output, then maybe I could see a place for that. But the hope would be that you've reinforced this positioning at lower positions or lower activities. So if we're talking about jumping, hopefully they're keeping some semblance of that during a squat and during low-level squatting activities and maybe during other table tests or table activities where you're emphasizing that. And the hope would be that it transfers to a degree to the terminal task. That would be one case in which I wouldn't cue a posterior tilt. In terms of an anterior tilt or orientation, I really can't think of any time in which that would be the go-to cue. Because most people's compensatory strategy is some type of anterior orientation. Because what that does is it allows you to get into a position where you're preventing falling forward. So I rarely see someone who gets into this crazy posterior tilt as their compensatory strategy. There's more degrees of freedom available when you get into a more flexed position. If I need stability, especially in the axial skeleton, and if you look at some of the pain research, I'll link some of the variability stuff in the show notes, but in the axial skeleton, variability is reduced. In the extended position in the spine, that is the closed pack position of most of the joints there. So I can't envision many people utilizing a flex strategy to enhance stability. So I don't really cue in anterior tilt. The only time I would really emphasize that is if any type of posterior orientation was a problem. And it's few and far between, but most people need the tuck because most people are limited in hip extension. And doing this is no different than doing this. But it is oftentimes way harder to do hip extension if you don't control the pelvic orientation. To summarize that, I cue the posterior tilt to emphasize hip extension because most people are limited in hip extension. We don't emphasize anterior tilting much. I will put someone into lordosis if and only if getting into a posterior tilt is painful and I need to start them closer to what their normal positioning is. I won't emphasize posterior tilting at terminal activities much because I'm hoping that I've reinforced it enough at easier activities or activities where you can be more cognizant. And a lot of times that does lead to transferability. Do I anterior tilt people? Not really. Most people are already there. Why do we got to flaunt what we got? That would be my answer to your question, Tim and Chase. Awesome question. This last one, but before I dive into it, I do want to let everyone know that if you are looking at applying posterior tilting to your people, you want to come to one of the best seminars in the land, Human Matrix. It is coming your way. We got a bunch coming up this year. Locations, May 18th and 19th in San Antonio. All my exes live in Texas. Then at Hype Gym, June 8th and 9th in New York. We're going to be there. August 3rd and 4th in Cincinnati, Ohio. August 24th and 25th in Vancouver. September 21st and 22nd in Raleigh, North Carolina. October 5th and 6th in Boston, Massachusetts, and December 7th and 8th in Orlando. And there will be some 2020 dates already, but I'm not going to announce them anytime soon. The last question comes from my homegirl, Lucy. Lucy asks, yo, what it do, Big Z? How you living? When a referral out is warranted, what qualities do you look for in a good clinician? That's a doozy, Lucy. I will do my best to answer that question and hopefully hit a bunch of points that are relevant. So Lucy's a trainer. We are thinking of when a trainer is working with a client and this client is beyond their scope. And I think that that's going to be very different for each trainer. Beyond your scope could be you're not really good at working with someone in pain and you need to refer them out to someone who's better than you. But it could be your client wants to learn how to utilize kettlebells and you suck at coaching kettlebells. That's an appropriate refer out as well. You refer out when there is a hole in your game or a gap that you can't fill that your client needs to meet their goals. That's when you refer out. Things I look for, because let's start with a pain, because I think a lot of clinicians or a lot of coaches are looking to when do I need to refer someone out for pain. Things I look for. The most important thing is, are they a good person? Would you go and see them? Especially in the rehab population, your client is going to be spending a fair amount of time with this person, more so than they would a physician. Me personally, in good old Page America, I see my patients one-on-one for 45 minutes. So there's a lot of things that I can do and say to those people. You want to make sure that this is someone that your client would get along with. Because if you don't have good rapport, if they can't build and establish a good relationship to them, even if they got the best stuff in the land, it's not going to work. In fact, this week, I was working with this patient and we got a new therapist who came into the clinic. And this patient had worked with that therapist before. And she was kind of into some of the stuff that I was doing, but eventually, even though she was getting some symptom improvement, it was like, hey, this person did this person did that. And it kind of bothers me when patients tell me what I should do, even though I'll do it. But it's kind of, if you go to Pizza Hut, you're not going to ask for sushi. You want to go to a sushi joint. So why are you telling me what to do? But neither here nor there. So she came up to me and said, hey, I just think me going with this guy is going to be better for me. Is that okay? And I said, yes, totally fine. And I heard their session. Like they were laughing, joking. She was having a great time. And I will do that 100% of the time if someone and I don't jive. And that's totally okay. Even though, I try to be a cool dude and try to relate to everyone. I can't get everyone to like me. I don't sell ice cream. That's the only people who will be liked by everyone. So make sure they're a good person. They're someone you'd hang out with or someone that you think your client would gel with. Once you've established that, you want to make sure that this is someone who is going to evoke independence for your client. If you are referring to someone and they're one of those people that puts people back together all the time, a fixer instead of a facilitator, that's an unhealthy relationship. Because what's going to happen inevitably is your patient is going to feel something, or your client. They're going to feel something at some point. And their initial thought is, oh, I need to go and see so-and-so. When it should be, hey, I remember so-and-so gave me some stuff for something like this before. I'm just going to go implement that and see what happens. The objective or the goal of any rehab clinician should be to warrant yourself not needed. You are simply there as someone who can facilitate getting your patient back to whatever their goals are, getting them back to baseline. And then you hopefully can find a good coach to work with to take them above baseline. That should be the relationship. Unfortunately, many clinicians out there make a lot of money trying to create that codependent relationship. And I mean, in any relationship, you don't want that, whether it's a relationship with a significant other or a relationship with a clinician. We want to consider ourselves as guides along the rehabilitation process and trying to make patients feel independent, take ownership of their care, and that's really what's going to lead to long-term improvement, more so than me putting you back together every time you feel hurt. That doesn't mean that manual therapy doesn't have a place. It most certainly does. But we want to educate our people in the context that this is just one little thing I'm going to use to try to help get you back to where you need to go. It's really probably the most important things. Other things you want to look for, does that person look at the person comprehensively? Are they just looking at the area that hurts? Or are they taking into account other areas? Ideally, you have someone who looks at the whole body. That's my bias. But are they at least, if you got elbow pain, looking at your shoulder and your hand? Regional interdependence. That is kind of a big deal. When we move, we do not move as individual parts, but as a cohesive unit. If you don't have someone who's appreciating that, they might help you, but it might only be to a point. I think looking at that is huge. I also think finding someone who reinforces what the coach is trying to espouse, meaning are they talking to their patients about sleep? Are they talking to them about nutrition? Are they saying, hey, you need to continue training. This is really important so you maintain your conditioning levels. Do they create and facilitate that collaborative relationship? If you have a clinician who says, I don't want you doing anything, that's probably not good. They're probably doing you a disservice in that regard. Because you need to maintain your conditioning levels. Because one of the problems when you come back after rehab is becoming sorely deconditioned. And then it takes that much more to get you back to where you need to go. And it can take a very long time. So you want to ensure that that relationship is kept that way, that they make sure that they're reinforcing the message that you are espousing. Those would be the big things I would say you need to have in a rehab to performance relationship. Another one is they are not afraid to communicate with the coach, and vice versa. If you're trying to convey messages through the patient or the client, you got the telephone game going on for sure, because you don't know how they're going to take whatever you say. I can try to say the most non-threatening things possible, and despite my best efforts, the patient may take that a completely wrong way. Or I might say something and then they latch on to the one thing that I said, and that's now their problem. We don't want that to happen, because all that leads to are headaches between the relationship of the clinician and the coach. So if you can create that relationship where there's a dialogue between you two and you both are pursuing like-minded goals to ultimately get the client better, because that's what this is all about, then you ought to be in business. Those, I would say, are the big keys you want to look for from a rehab clinician standpoint. When it comes to specialists, well, I think bedside manner is still very big. I am less picky about some of those soft skills that I was discussing with the rehab clinician. When I want to work with a specialist who's maybe going to do a surgical procedure or going to prescribe some medications or some more invasive treatments, I want to find the best guy or girl that I possibly can. I want to find that doctor who has done this procedure 10,000 times and they're bored by it, because then it's automatic. Anytime that you have an invasive procedure, you want to mitigate any potential risks. Because if you have a surgery, guess what one of the big risks are of any surgical procedure? Death. So you probably want the best person at your craft, because if you have to go under again, you run the risk of dying. Minimize those risks as best as you can. Now, hopefully you have a physician who you can have a dialogue with and is receptive to what you're doing. But if you have that and that negates the skills that are warranted to perform whatever procedure it is, go with the person who knows what they're doing. If you're concerned about maladaptive beliefs happening with that person, have solace that that physician is spending way less time with your client than a rehab clinician or yourself. Please pick someone who is good at what they do and they're bored by it. Those are really the big things I'm looking for if I want a surgeon. When I got my tongue done, I reached out to my boy Joe Cicinelli. Holla at you. I'll link him in the show notes because he's the man. And he got me the best guy in the country. Now, fortunately, Dr. Zaghi, I'll link him in the show notes too because I'm a big fan of him. Fortunately, he has pretty good bedside manner. But he's also the best at what he does. So even if he was a complete dick, I wouldn't care because I got the best guy cutting on my tongue. You want that for any type of medical procedure. So to summarize your wonderful question, Lucy, big keys: you want to make sure they're a good person. You want to make sure that they are a facilitator, a guide, not a fixer. If we're talking rehab clinicians, you want to make sure that they take a multimodal and holistic approach. See what I did there? A multimodal approach. They're looking at the entire body, they're reinforcing your message, and they're not afraid of having dialogue with you. Those are the keys for a rehab clinician. If you need something a little bit stronger than that, get the best of what they do. Seriously. Because there are much greater risks when invasive procedures are going to happen. You want someone who's really good at those. And if you do those things, your clients are going to get the best possible outcome. Thank you so much for tuning in, because I think that's a good stopping point for us. If you want to find out more about me, go to zachcouples.com. I just redid the site so it's all sexy and whatnot. There, sign up for my newsletter. You'll get almost probably like 4.5 hours of me talking about stuff, breathing, pain, and it's free. You're going to get a free acute to chronic workload calculator. You're also going to get weekend goodies from me every weekend. If you want to know what's going on the interwebs, I'm your guy. While you're also there, you'll want to sign up for my services. I offer 3 movement consultations. If you want to apply posterior tilting to yourself because you lack hip extension, and maybe that's getting you tight in some other areas, I'll be your guy. We will take you through a full body movement assessment. I will address any movement limitations you have, show you what to do, and I will be your facilitator, your guide towards movement freedom. Definitely check me out for that. I also offer mentoring. If you want to learn how to apply some of the posterior tilting that we talked about today, or you need some guidance with rotator cuff rehab, we can talk through that. It'll be a nice, good back and forth dialogue. I ask you what your holes in your game are, and it's up to us to work together to fill those holes so you can better help your clients. Definitely hit me up for that. Maybe you just want to get yoked, or you're post-rehab, you're unsure where you want to start getting back into the weight room. I can be your guy. I will write you a tailored program after we do a movement consultation specific to your needs, and will help you reach your goals faster than ever before. Once you've scoured zachcouples.com, you'll want to sign up for the Zach Couples Show on iTunes and Stitcher. Because guess what, folks? There's 75 other debriefs. I get it, I got this nice beard and whatnot, but do you really want to look at me for all of them? Bring me on a long car ride. I like them, especially ones along the beach. Definitely sign up, and please leave a review so we can help the fam grow. Other places you can find me, I'm all over social media. I'm on Facebook /ZCouples. The Twitter handle is @ZCouples. The Instagram, baby, Zach, Z-A-C, Couples, C-U-P-P-L-E-S. And last but not least, if you go to YouTube, search Zach Couples, you will find a gazillion activities to implement for yourself, for your clients, your loved ones, whoever. Thank you so much for tuning in. I appreciate each and every one of you beautiful, sexy, outstanding people. I want you to keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.